So we have a new wave of therapies, shall we say, which enable us to target the driver mutations better. So CALR lends itself particularly well because it's expressed on the cell surface because of the mutation, right? So it comes out of the endoplasmic reticulum or loses its retention motif, comes out and can be targeted. So why don't you tell us about the ways to target mutant CALR?
Right. So just as you mentioned, wild-type CALR is in the endoplasmic reticulum, and once it's mutated, it actually ends up extracellular, and it leads to ligand-independent constitutive activation of the JAK-STAT pathway. And we have two new therapies that are targeting CALR. One is a monoclonal antibody made by Incyte, and it's in the JAK inhibitor either refractory or intolerant setting for those who have myelofibrosis, in addition to those who have a CALR mutation up front for ET. And data is very preliminary right now, but it appears that we have great responses for those with ET in terms of symptoms and spleen. In addition to those with myelofibrosis, we're seeing good responses as well. In addition, there is a bispecific antibody that's also targeting CALR, and that is very preliminary, but it appears there are responses as well in that space, specifically for spleen.
And that's the J&J compound.
Sorry, that's J&J compound. That's
right,
correct.
Right, yeah. Right. And also, and I think Nasima just alluded to this, we are also going to have hopefully better JAK inhibitors, right? So we have the Incyte mutant selective JAK2 inhibitor. And then we have Ajax, which I think is a really kind of a cool and unique compound where, a number of years ago, Ross Levine's lab had published that the main mechanism of resistance to our type 1 JAK2 inhibitors is this persistence phenomenon, where there's a heterodimerization occurring, and even if the drug is bound, the signaling can persist through a heterodimer mechanism. And so now we have this type 2 inhibitor from Ajax, which binds to the inactive conformation, whereas all 4 of our approved drugs bind to the active conformation of JAK2, and is able to, at least in the lab, overcome this persistence phenomenon. So that's also in a phase 1 trial. So another thing I really want to touch on, and Ido, I'd like your thoughts on this to start us off. Symptoms, right? So Pankit told us about pelabresib, but then there was also navitoclax, neither of which met the symptom threshold, right? 2 big phase 3s at ASH 2023, lots of excitement, but both kind of doubling the spleen response, not really meeting the symptom benefit. And one thing I love that Ruben Mesa always says is that a new drug can either make people live longer or live better. And I think Ruben just puts that so extremely nicely, that FDA is looking for one of these things, right? So symptoms, and that goes back to the MPN10, the whole TSS50 concept. All this is a legacy that Ruben has left the field. But what does everyone think about this symptom piece? One, how important is it for our patients, just regular day-to-day care? And two, as far as a regulatory endpoint, because some drugs are getting stuck at this one.
Right, it's a great question. Clinically, and I think for all of us, when we see patients, we want them to feel better when we give them a therapy. So symptom improvement is important, and also it functions as a surrogate marker for, when we think about the JAK-STAT pathway, you're thinking about how it regulates signaling for cytokine production. And when we think about cytokines, those cytokines that are being produced actually function in 2 ways, right? One, for the patient, they don't feel well. Also, 2, when we think about the way that this disease functions, MPN, there is that component of the extrinsic pathway that may contribute to clonal evolution outside of the driver mutation. So I think controlling cytokine production is important. For us, symptom control is a surrogate marker for that. So So I do agree with you that that's very important.
Are you using the MPN10 in your clinic, like regular regular practice?
Yes, yes. We actually every patient that comes in, we do use that. Now, to your second point about the regulatory hurdle that I think some of these trials are dealing with, it does present an issue. Navitoclax as a good example, as I have patients who had great responses clinically, and unfortunately the drug, did not get over the hump. And I think we do have to identify other ways of, not only thinking about symptoms, but thinking about surrogate markers for disease control. And obviously, everyone in this room is very bright and smart and would be able to kind of give us better ideas on how to do that. But I think that does, it does affect our armamentarium in fighting MPN. And so I would love for us to be able to kind of figure out a better approach here for that.
It's good to hear and see that you use the symptom assessment form very regularly. I'll say that I'm not a saint, but I'm also not a sinner. It's hard to do the symptom assessment rigorously on every patient, but to your point, Ito, I do try to use the symptom assessment form. It's actually printable from NCCN guidelines if you want to do it and use. Many EMRs now incorporate this as well
Epic has it.
to track it very well. I'd like to do this upfront at baseline, but when a patient comes in newly, and the good thing that I found is when you do these symptom assessments at baseline and perhaps even down the line, you sometimes uncover symptoms that patients didn't tell you first. Sometimes they realize that they have symptoms that they just didn't know about. After all, MPNs, myelofibrosis, this is a chronic neoplasm. It's been there for a long time. Patients have gotten accustomed to the underlying condition. They may underestimate sometimes their own symptom burden. So using it at least at baseline for most patients is a good idea, and then I try to do it every, maybe every 6 months or 12 months, or on an as-needed basis when I feel that perhaps things are changing. And when it comes to symptoms, in addition, I think the one way of looking at the symptom assessment is to cluster some of these symptoms. So yes, there are symptoms which are predominantly from cytokines, as you were mentioning, through the JAK-STAT pathway being hyperactive. And those could be things like fevers, weight loss, constitutional symptoms, night sweats, bone pain as well. Then there's a unique cluster of symptoms related to spleen being enlarged, or perhaps even liver being enlarged, early satiety, left upper quadrant discomfort or rib cage pain. And then there's the anemia-related symptoms. I think we may have not paid so much attention before, but now knowing that there are anemia-related symptoms, dyspnea, although it's not fully captured in the symptom assessment form as is, it's important to check that. Fatigue, definitely a multi-etiology factor, but also one that is definitely also correlated with anemia and its severity. Important to check that now that we have options beyond Rux monotherapy. So for example, if patients complain of symptoms like headaches, fatigue, easy fatigability, and they report shortness of breath, so these things may tell us that, all right, a patient's hemoglobin of 9, although it doesn't look terrible, maybe we should add anemia supportive medications, or maybe we should switch to momelotinib in those scenarios if anemia is a predominant thing for those patients. And one other thing about the symptom burden issue is that it's one thing to have symptoms and recognize that there is symptoms, another to quantify, and the third piece, which to me is very important, is the symptoms then affecting the quality of life. So I like to ask patients in the clinic, how does this actually affect you? Have you reduced the number of hours that you work? Can you not go to the social events that you wanted to go to? And to that endpoint, the landmark studies done by Claire and Ruben in US and internationally both showed that these do have an impact, and treating with JAK inhibitors does improve these things.
Naseema, let me also ask you, beyond what we, what Ido and Pankit described. I'd love to get your thoughts also on the regulatory aspect, right? Because so far, TSS50 or however you measure symptoms has been a requirement. And I would love to get your thoughts on what you think, whether going forward it should still be a requirement as we get into non-JAK drugs, etc.
So I think we're into a very interesting discussion on symptoms. Symptoms are very subjective, and even patients, when we give them these forms to fill out, they are sometimes have difficulty quantifying. The MP&SAF, these are good questionnaires, but when I compare, the patients are generally doing better, but then they mark something, they're long, they're very cumbersome, and they're still very difficult to standardize some of these PRO endpoints. And as we move to non-JAK-I drugs, especially anemia drugs, we're going to have to look at different PROs for myelofibrosis because they could have high spleen-related symptoms or, pruritus or, night sweats, but that's not going to be impacted by the anemia drug. So as we go into the regulations, and that's what we are kind of looking into as we develop agents like luspatercept for its approval and DISC 0974. So if they're going to get approved for anemia, I think we have other measures like 6-minute walk tests and other things that may need to be mandated to objectively quantify that if a patient is saying the hemoglobin is up and they're able to do better, we are demonstrating in an objective fashion as well. So I think the field is really evolving. The PRO field in general is a very subjective field. It does require a lot of work, and as we borrow some ideas from that field, there are some established endpoints and questionnaires too, but in the MF world, we still have to kind of adopt some of those as we move to the things. And then the other point to highlight is also symptoms related to drug therapy. For example, if it's causing side effects, would you call them symptoms? For example, with pelabresib, there was dysgeusia reported in a significant proportion of patients. So that would also contribute to symptom burden. And there's, of course, tolerability of symptoms are also variable depending on the patient threshold, like how stoic. Some patients, even if they have a lot of diarrhea, they won't tell me they have diarrhea until I ask them how many stools a day. So I think this is a evolving area, and we as a community need to get together and perhaps even have working groups focusing on symptoms. We have a lot of groups focusing on drug development and disease biology, and we may need to kind of take the lead on some of those areas too in a new fashion, like moving beyond MP&SAF and the TSS50.